Yeah, so welcome to the fourth webinar in the spring series being organised by the HRB Primary Care Clinical Trials Network Ireland. I will introduce our presenter today, Dr. Peter Hayes. Peter is a lecturer in general practice in NUI Galway, and he is also a GP in Dr. Michael Griffin practice in Limerick City. Peter graduated in medicine from UCD in 2003 and completed a vocational training scheme in general practice in Limerick in 2008. He has also completed a Master's in Medical Education from the University of Dundee in 2016. Peter has an outstanding record as a researcher. He has particular interest in hypertension and cardiovascular disease, medical education, drama and medicine. On behalf of the network, I would like to thank Peter for hosting our webinar today. So I will hand over to you now, Peter, if that's okay.
So, I hope you can hear me. Everybody can hear me clearly?
Yeah, we can hear you great. Thanks, Peter.
Okay, so today I'm just going to talk a little bit about managing resistant hypertension. Oh, good, I'm on the camera live. So, I suppose it's been a topic that I've been working on, various different research topics on resistant hypertension over the last 3 to 4 years. And we're just going to chat a little bit about the management, and I'm going to give you some of the basic research that we've been doing over the last number of months, or we're finalising over the last number of months. And so I've set up a problem at the start, and we're going to talk a little bit about the research that we've done, and then we're going to try and look and see if the research can guide any of the solutions to the problem that I elicited at the start. So we've just recently been given our British Journal of General Practice DOI, which was very exciting. We've just been waiting and approving proofs on this paper, which was about apparent treatment-resistant hypertension in general practice. We did a cross-sectional study in Irish general practice to try and ascertain a prevalence figure, how big this problem is, and then to consider morbidity, various different morbidities that these patients may have, and a term called pseudo-resistance. Now, pseudo-resistance, I'll go into in a little bit more detail, is not too complex to understand, but it's a broad-based term. So the case study would typically be something like MIC58. It takes ramipril 10 milligrams once daily, amlodipine 5 milligrams once daily, and bendraflumethiazide 2.5 milligrams once daily. He has type 2 diabetes. He takes oral hypoglycemic agents. He has COPD, osteoarthritis, and gastroesophageal reflux disease. But his last 3 manual BP readings have been 162 on 86, 168 on 78, and 160 on 85. These have been over the last 6 months. This is a common clinical scenario. And I suppose the question is I want you to think as we go through the research is, how do you manage this? How would this be managed? Or how could we approach this from a general practice primary care team point of view? So our initial study was we wanted to do a cross-sectional study of the prevalence of this resistant hypertension. We wanted to use the proper definitions, AHA and ESC, American hypertension and the European Society of Cardiology definitions. But we wanted to look at different morbidity because people who have different morbidities have different target rates. And certainly when we started out, that was certainly true, although this seems to have leveled out more and more over the last 2 to 3 years. But initially, when we started out, people with chronic kidney disease and diabetes were to have lower target blood pressures than those who didn't. So we wanted to look at pseudo-resistance as well, which the 3 main parts of pseudo-resistance are white coat hypertension, dosing issues, and adherence, are people taking their medicines. And we wanted to see, could we consider these issues from individual patients' files? So just a bit of terminology. Treatment-resistant hypertension is blood pressure which is uncontrolled by the use of 3 medications, a bit like MIC there, at optimal doses. One of the medications should be a diuretic, but it's also anyone who needs 4 tablets or 4 medications to treat their BP. Lifestyle issues should always be addressed as well when you're considering hypertension, and especially resistant hypertension. Now, apparent treatment resistant hypertension is a coarse head count. So you don't really look at the effects of lifestyle, white coat hypertension, poor adherence to the tablets that are being prescribed, ineffective dosing or inadequate dosing, or secondary hypertension, which can also be a cause of resistant hypertension. If none of these issues are assessed or looked at, and we're basically looking at a spreadsheet of high blood pressures and people who fit the medication criteria, well, then this is the apparent treatment-resistant hypertension group. True resistant hypertension, obviously, is those who remain after you've excluded white coat hypertension, lifestyle, medication adherence, dosing, and secondary causes for hypertension. When you rule all these things or evaluate these, the group you've left have true hypertension. So these things that we evaluate, these are pseudo-resistant causes for hypertension. So somebody who has one of these issues isn't really resistance, they have pseudo-resistance. So a meta-analysis looking at how big a problem was the prevalence of resistant hypertension, they actually looked at apparent treatment-resistant hypertension because that is what largely studies look at, because a lot of the studies are based out of large databases. And for 20 different observational cohorts, the prevalence amongst hypertensive people who are hypertensive was about 13%. They looked at some randomized controlled trials where data was available on resistant hypertension, slightly higher on 16%. So this seemed like not an insignificant problem when we initially started looking for background data on the problem of resistant hypertension. But we weren't entirely happy though with some of the work that was available. A lot of the work was not based in primary care. A lot of the work was based in secondary care clinics, selected populations. A lot of the work was done on large databases available from health insurance, therefore excluding people who didn't have health insurance. So we weren't sure, even from the vast quantity of papers that were in this meta-analysis, maybe 24 different papers, we still weren't sure that the prevalence of resistant hypertension, the actual prevalence, had been correctly identified. So that was one of our main aims in the study we did. So basically, with 16 practices, we invited 40 from the West End network. The practices ran a standard drug search identifying patients on any possible hypertensive medications. We used the BNF. There was actually a tool built into Socrates, and that's the best way to describe it. And the tool could quite easily identify patients who were taking 3 medications and give you their basic blood pressure readings. Not quite as simple as that, because it actually had to double check some things in patient files. So then, once these patients were identified, 2 researchers reviewed the record of each individual patient, and we had a look to see whether they were hypertensive or not, what treatments they were currently receiving, and whether they had treatment-resistant hypertension or not. So essentially, the practices facilitated the lists. We identified these patients, but then we kind of had to work with the practices and then clarifying a group of patients who had potentially treatment-resistant hypertension. You can see the network there, largely for geographical reasons, because we needed to be able to potentially refer these patients into the specialist tertiary clinic in Merlin Park Hospital, run by Dr. Faisal Sharif, Dr. Conal Dennehy, and Dr. David Lappin. This is quite a novel clinic. It is a multidisciplinary medical clinic linked in with endocrinology, cardiology, and renal medicine all combined. So that's why we kind of had to take, I suppose, the southern Connacht region, Limerick, Clare, Tipperary, and just into the Midlands, because people needed to be able to get to Galway if needed. So the cut-offs we used, the hypertension, your typical ones, the 140 and 90, as I said, the diabetes and the chronic kidney disease had a lower cut-off. And we also wanted to play around a bit, because elderly in practice, from HIVET data, had always been given higher targets, 150 on 80. Now, this may or may not be true, and there's a lot of debate currently about how low should elderly patients be treated to, but we wanted to consider the 150 on 80 figure. And just if we were using ambulatory blood pressure monitoring, we wanted a daytime mean. The typical daytime mean, being the cutoff of hypertensive or not, was 135/85. So white coat, patients with a normal ABPM within 6 months, despite having high elevated manual readings, were excluded. Like, they don't have treatment-resistant hypertension. This is white coat hypertension. So patients look like they have hypertension in the clinic, but actually the ABPMs are normal. To look at dosing, we wanted to look at the tablets that patients are on and what can you compare the dose to. what's the right dose for a hypertensive patient to take? The World Health Organization do give a defined daily dosing guidelines, and you can see these as a website there. But if you put defined daily dose, World Health Organization, you can actually see the defined daily dose for any med. So we compared the meds these patients were on versus the defined daily dose that was available on the World Health Organization website. Egan et al. Are another group who looked at dosing. But they kind of made up their own marker because they felt obviously the World Health Organization is a kind of a gold standard. They felt that was maybe a little bit harsh. So what they basically had their own local formulary, and that they said you were adequately dosed if half the tablets you were on met what their formulary said you should be on. So we looked at it both ways. Adherence, typically it's 80%. Now where 80% comes from, it's not quite clear. But you're adherent if you take your tablets 80% of the time. This is across the literature and accepted. We couldn't quite reach the 80%. And this is because in Irish contexts, especially in general medical scheme contexts, drugs are often dispensed quarterly. So if somebody receives 3 quarterly meds, that's 75%. So we had 75% as a cutoff. So within a 1-year period, you had to largely have at least 3 quarterly dispensations or prescriptions printed for you in your practice. So that's what we looked at. On the computer system, were patients getting their medicines printed for at least 75% of the time. So the cohort, about 50,000 if you look at everyone. On at least hypertensive, we estimated about 7,000, which these were adult patients. So you're probably looking at something like 1/8 of patients, adult patients having hypertension. It was complex to drill down as to who exactly had apparent treatment-resistant hypertension because some of the lists, we printed off vast swathes of data and we had to manually go through a lot of this. But we identified 646 patients out of the 6,691 hypertensive patients. About 10% had apparent treatment-resistant hypertension. So we're taking the 3 meds or 4 meds to try and control their blood pressure. You can see the demographics, a high preponderance of PCRS availability. Just some other interesting things that we thought was that actually this was, when we did this cross-sectional study, so this is a cross-section in time, we just went in, it was actually before the ABPM funding model was released. So you can clearly see there that those who had systolic clinic BP, you can see it here, 142 was their average blood pressure systolic reading. But those who had the daytime ABPM mean was 147. If you see it, it's 3 or 4 below that. So that actually meant that you only got an ABPM in the good old days if your blood pressure probably looked higher. So these were patients who had higher blood pressure. And that was just an interesting thing because GPs were clearly being pragmatic about who was getting the ABPM, and that was an interesting finding for us. Just if you look at the prescribed at least one combination med, close to 2/3, which is interesting. So combination meds were being used. But now, if we look at adequate dosing, so if we're saying according to the WHO defined daily dosing, we could say that adequate dosing was actually only present in 19% in all the tablets. So 1 in 5 had all their tablets adequately dosed. So that was quite a good finding, we thought. But it gets a little bit more interesting. This is when you look at broad figures and then you drill down, you actually see what's happening. So I'll go through that a little bit later. Just with adherence, we found about 80% of people actually got at least their medicine 75% of the time. But 20% didn't get their medicine 25% of the time, or more than 25% of the time. But this was the measure we used. Obviously, you can collect your prescriptions, but that doesn't mean you take them. So we accept that, but this was the measure that we were able to use and drill down. But 20% of people couldn't have taken their tablets because they didn't have prescriptions for these tablets. And obviously, we could only base the adherence figure on those who were PCRS eligible. So if we look at a meta-analysis of the various practices, these are looks fancy, and it is a very great thing done by John Newell, statistician, but it's basically the 16 practices, and we're looking at the prevalences, and you can see that the prevalences actually vary quite significantly. The prevalences of the resistant hypertension amongst the hypertensive group, you can clearly see that there is some variation, but the average figure works out about 10%, okay? Which seems very close to the initial, we'll say the initial cut figure. The reason we put these into a meta-analysis is practice sizes are different, so you have to adjust for practice size. You can't just take a course percentage figure, but it still worked out roughly the same. Whether you used a fixed effects model or a random effects model, these are statistical terms, just looking at, it depends on the data you have as to which model you use, but it didn't matter in this instance, they were the exact same. But we wanted to regress this slightly. We wanted to look at the diabetes. We wanted to look at people who were over 80. Whether you had diabetes or over 80 and you got lower or higher thresholds for the blood pressure, it didn't make a huge difference. It still stayed around 9–10%, the prevalence of resistant hypertension, or apparent resistant hypertension, which is actually what we were looking at. But when you start to add in dosing issues, the prevalence drops to 4%. And when you add in adherence, it drops a further percent, maybe to 3%. So now we've gone from the situation back in these meta-analyses where people are saying amongst the research that basically between 10 and sometimes up to 30% of people have apparent resistant hypertension. They look like they're not controlled at all. But when we drill back down in this cross-sectional study, we're seeing that it's probably 3%, that actually most hypertensives are controlled. And the question started to arise to us then, is this an overdiagnosis? Is this an issue that has been blown out to be bigger? And you must politically, I suppose, fix this in at the time, what was going on. There was a particular drive, not so much in the last 4 years, but maybe in the 5 years prior to that, for advanced therapeutics to treat hypertension. Things like renal denervation, baroreflex activation, and various anastomosis has been done between veins and arteries and legs, and different things. So this kind of research base was beginning to expand. Renal denervation was starting to take off. Was this something that was going to save everyone from having to take tablets, and we could just basically burn the sympathetic nerves around people's renal arteries, and that this would stop people from becoming hypertensive? So all this was going. Renal denervation, funnily enough, the evidence base over the last number of years has shown that we're not quite sure if it works. And really, it shouldn't become a mainstay yet of therapeutics until a lot of further work is done. So if you were in those instances and renal denervation was so popular, you could see why having high prevalences of resistant hypertension may have been seen as popular. But when we drill down in this study, we can see that we were finding that it wasn't as large a problem as it seemed. So basically, what I wanted to talk about, the drug dosing, though, was an interesting thing. If you look on the far right, you can see that anything in green is kind of good. So the RAS drugs were all adequately dosed. If we look at the alpha blockers, doxazosin and this, all adequately dosed. We go down to the calcium channel blockers, green, 97%, pretty much all adequately dosed. The main groups that weren't adequately dosed the most were the beta blockers, the rate-reducing calcium channel blockers, and various diuretics. And this is really probably a pragmatic decision that's made by general practitioners, because these are the drugs that give the side effects. It makes sense. The requirement when the WHO defined daily dosing for bisoprolol is 10 milligrams. I mean, 10 milligrams in the elderly is a huge dose of beta blocker, and it's, these are often people with damaged hearts. You'd be very reluctant to do that. So it's a pragmatic and wise decision, maybe, that people don't go to 10% of bisoprolol. When we look at the diuretics, we can see that the loop diuretics are a little bit better dosed than the thiazides. The fear with thiazides, of course, is electrolyte disturbance largely, and there can be complications around different metabolic complications with the use of thiazides. But I suppose hyponatremia, big issue. So drug dosing looked like it was a significant issue, but when you drill down, maybe not so much. Pragmatic decisions, and that's just further evidence of what we looked at, a little bit more data. So what we're saying in this box plot is basically 2/3 of people really, you can see that this box plot is the middle kind of, is basically where most of the data lies. There's only one quartile to the end. So 3/4 of people are taking about 70% of their tablets at the right dose. So I mean, it's not as large as the other figure shows. So just, I wanted to say a little bit about some of the issues we came across with the drugs. It seems to us that alpha blockers have been used more readily as a fourth agent. So when people typically are taking a RAS drug, when people are typically taking a thiazide, when people are typical, when I say a RAS drug, everyone knows that I'm talking about the ACE inhibitors and the ARBs. That's what I mean, renin-angiotensin system drugs. So you're either taking a ACE or ARB, you're taking a thiazide, and a calcium channel blocker. That's your typical potpourri for patients taking to try and control hypertension. When you're stuck and people are adding in a fourth med, what we're saying is people seemingly in an Irish context are using the alpha blockers. The recommendation is actually a mineral receptor antagonist, spironolactone. That's what the papers say. But there's a fear with spironolactone, and rightfully so, especially in more rural practices where the ability to get serum potassium is low, or to get false serum potassiums if samples can't get into laboratories quick enough. And there's a fear about using MRAs, especially in people who have chronic kidney disease. About 2/3 of this group, 60%, 65% of this group had chronic kidney disease. So I can understand why GPs are reluctant to use the fourth agent. And this seems, again, a pragmatic decision, but why, and the evidence behind using the alpha blocker, it isn't there. It suggests that the spironolactone is better, but why GPs are in primary care choosing to use alpha blockers hasn't been fully investigated. The only thing I would say is that the thiazide diuretic of choice seems to be the HCl thiazide. It's frequently found in the combination drugs. But there's about 18-20% using less potent thiazide drugs, such as bendroflumethiazide. And bendroflumethiazide is a good drug. It can control blood pressure in lots of patients, and patients can successfully take it maybe without side effect. But I suppose if you're targeting this higher risk group and you're trying to reduce blood pressure, and this group are resistant to treatment, maybe you need to change the type of thiazide you're using rather than sticking with it. So now back to Mick. So Mick takes ramipril 10, amlodipine 5, bendroflumethiazide 2.5. He's all these diseases or issues going on for him. A lot of tablets, maybe 10. His manual readings have been in the 60s, the high 60s sometimes. How do you manage it, and what are you going to do? So I'd be interested just to hear if anyone had anything to say, or anything they felt they might like to add to this.
Peter, while people are thinking of that, there's just an interesting question in from Andrew in the chat asking the potential impact of data protection laws on your study methodology if done next year.
Yeah. These are the new EU regulations that have come in. I think consent for access to data is going to become a huge issue. I mean, typically within these scenarios, practices have been doing audits, and it's a requirement of medical council for practices and general practitioners to participate in audit. And sometimes some of our research has been tied up with audit. I think it is now becoming clearer with these new EU regulations that are going to come in May that consent is vital. Ways around this may possibly be that practices will have to go back to their own specific patient groups and speak to their specific patient groups about data. And maybe the persons joining practices may allow for the release of anonymous data, or practices may have to go back to their own patient groups, discuss what anonymous data means and why anonymous data might be used for this and that and for research, and are they okay with that? And that may be some solutions. Great. Maybe I might move on and just discuss the therapeutic options. So the management plan for Mick, I took this largely from Richard McManus's Diagnosis and Management of Resistant Hypertension. Richard McManus works in the University of Oxford in the general practice, basically department, and has done enormous amounts of work on home blood pressure monitoring, ABPM, and resistant hypertension in itself, and hypertension, cardiovascular disease. So an approach for MIC would be simple things: check the medicine potentiators. Anti-inflammatory drugs. Is somebody taking them, or are they buying them over the counter? Is somebody using decongestants, or are they buying them over the counter? These are vital. And licorice comes up consistently. And I'm advised by my colleagues in the hypertension, tertiary hypertension clinic, that a lot of people take a lot of licorice, and that it's important to have these conversations with patients that licorice is a vasopressor and can rise blood pressure. Simple things: stopping smoking. Get the salt in diet reduced, especially if there's a heavy diet of processed foods. Looking at the DASH diet: more fruit, veg, fresh food, cutting out added salt, and general exercise and diet, getting people going. Lifestyle, again, is key. If you look actually at the research on this area, there's very little on lifestyle. And these could be very important factors in reducing blood pressure for people. But a lot of the research work on resistant hypertension doesn't really assess the success or assess lifestyle adequately, in my view, in any of these patients. So we'd use an ABPM to rule out the white coat hypertension. That'd be very important. Are people resistant at all? Have they white coat hypertension? Drug adherence is an interesting thing. You can obviously have a chat, and you can look at the refill counts as I described. See, are people collecting their scripts at the right time every month? Or you can use a questionnaire. The Maritsky eight item questionnaire is a good one, and I have a copy of it that you can see shortly. It's 8 questions to go through with people, and if they answer, I suppose, in a non-adherent way to 2 of them, well, then these patients can be deemed to have issues with adherence. Improve dosing. So that's key. Amlodipine in this instance was increased to 10, and I changed the bendraflumethiazide to indapamide or HCl thiazide, and maximize the thiazide dose, but being wary of the electrolyte side effects, be aware of them. The 4th line, GP's choice is the doxazosin or adding in a beta blocker, perhaps carvedilol actually, which is a beta blocker that has some alpha blockade and is probably one of the most successful in reducing blood pressures, is underutilized in what we saw. The evidence-based choice is the spironolactone. Again, being aware of hyperkalemia and those with chronic kidney disease. And if there's issues with gynecomastia, maybe it's causing eplerenone. 4th line, other choices in chronic kidney disease, perhaps loop diuretics in place of thiazides. Very important. The addition of amiloride, if there's issues with hypokalemia. And clonidine gets some traction. And a recent paper released on the use of clonidine as the 4th agent, but it didn't show any significant improvements really to spironolactone, and seemed to have more side effects, especially sedation. So you refer for review, basically, anyone who has secondary hypertension. Okay, so if there's clear concern about chronic kidney disease, primary aldosteronism, renal artery stenosis, sleep apnea, pheochromocytoma, Cushing's, Cushingoid, or coarctations, which are rare and usually found in pediatric populations, but occasionally are missed. And there's a delay to the femoral artery, of course.
Peter, sorry to interrupt, but there's actually a question in from Andrew asking, how should we, in the study and with individual patients, check for sleep apnea?
Yeah, the sleep apnea is a complex. It's complex to diagnose this. Basically, a lot of the experts in obstructive sleep apnea would say that the questionnaires actually identify vast swathes of people, and many of whom who don't have obstructive sleep apnea. So in primary care, it's very difficult to use a questionnaire. It'll identify a lot of people, many of whom don't have sleep apnea. So in primary care, It's not easy. I think it's probably based on taking an extensive history and taking an extensive collateral history, which is vital in sleep apnea, typically from partners or sleeping partners who can verify episodes of apnea overnight. I think that's key. Questionnaires, the success of these in identifying patients with true sleep apnea is dubious in my view. So great. And obviously specialists, there's advanced therapeutic options that primary care isn't going to deal with. These are nitro patches or off-license vasodilators, and these are commonly used, things like hydralazine, typically used in specialist or tertiary referral clinics. And in real extreme cases, obviously there are therapeutic trials ongoing with the use of further use of renal denervation and other such advanced therapeutics. So that would be my suggested management plan: medicine potentiators, lifestyle being addressed, ABPM to rule out white coat hypertension, adherence, see if you can establish if adherence is an issue. And we're currently developing, as part of this was a HRB funded study, we're currently have a knowledge and dissemination project that's underway about how to help practitioners in primary care settings deal with patients who are non-adherent. So that's an exciting thing that we're working on, and we hope that that will be widely available for people working in primary care over the next number of months. So adherence, looking at the dosing is certainly that you can do. And if you feel that the dosing is okay, adherence is okay, and there is no white coat hypertension, making a pragmatic choice and a comfortable choice for you on the type of fourth line agent that you'd like to add. All the time, again, looking for who needs to be referred. Are there clear issues with secondary hypertension, or are there people who have had de novo hypertension that's just, taken off rapidly? These people would need to be evaluated in clinics. That's great. So, thank you all. If there's are there any other final questions? Anyone have anything to say? Great.
That's brilliant. Thanks a million, Peter, for delivering such a high quality presentation. And I'd like to say thanks on behalf of the network for you giving your time to deliver this webinar. It's fantastic.
Okay, thank you very much, everyone. There
doesn't seem to be any questions coming in, so I think we'll wrap it up now. Thanks, Peter. Thanks very much. And thanks everyone for joining in.
Take care. Bye-bye.